Today we have Dr. Rachel Martin, a new podiatrist, is joining us. Welcome.
Thank you. Thank you for having me on your podcast.
Grateful to have you. And I just got a brief summary of your training. You're originally from Peoria, Glendale, but went to U of A for undergrad, and went to California for podiatry school, and Indianapolis for residency.
That is correct.
Tell me about your training. Was it any particular focus on, forefoot, hindfoot, wound care, or any kind of special focus, or more of a diverse, well-rounded program?
I think my program was very well-rounded and had a good variety of everything that you could really want to get from a residency program. They did have wound care centers, which I felt was very helpful in having to be able to treat a patient in that aspect, as far as, because treating wounds just directly in an office can be difficult in order to provide the patient with the best care that you can possibly can. As far as being able to get the resources, we saw a lot of rear foot from specific doctors who were very highly trained. We saw forefoot from other doctors. We had a good relationship with the orthopedic doctors that were up there. There were certain rural areas that we went to. And so because of that, we were able to see some trauma, which is not what all podiatrists get to see, unfortunate for those podiatrists. So that was lucky for us that we were able to see that.
How about working with the vascular surgeons in terms of wound healing, revascularization, and then working on the feet?
Yeah, so we were very tight knit with our vascular surgeons and doctors, like actually on a texting basis with them. Because we were in the wound care centers and vice versa and rounding, like they would be like, hey, can you guys come take a look at this? And like we would also be like, I think this person needs intervention. And because we had such a close relationship, they knew if we were sending them something, it really meant something, and vice versa. And so we had a very respectful relationship with them, and it was really great.
Yeah, I always found that during the residency, there's such a close working environment because, we're in the hospital all the time and meeting each other and talking to each other. But out in the real world, the communication is lacking. For example, like a podiatrist will write a note, and then sometimes it doesn't even get sent to the vascular surgeon. And then we'll get a patient and have no idea what they want, like no idea what they're trying to do, what their problem is, what their issue is. And so we're just starting from scratch, do both arterial and venous, workups, and then lymphedema workup, and trying to find out what the problem is, where the problem is. And so in our practice, I found that it's a lot easier because we have these group chats. We can text each other. Scribes can text each other to really communicate that information. Like I know you just came out of the training, so it's not you haven't had much experience in the kind of real world clinical practice where solo practitioners are trying to communicate, and their staff is calling another doctor's office and they don't return the call, and it just care just becomes so fragmented. Working with vascular, and in our training, we work with a lot of great podiatrists, excellent surgeons, trying to do their best and trying to preserve toes and prevent the amputations.
Yeah, exactly. Like that's why I'm really looking forward to being in this multidisciplinary group, is that we will be working with vascular so closely that it will be easier to get the patients the care that they need, and more accessible for the patient, and that they will be given the best care. Whereas, sometimes it's a little bit more difficult if a patient's going to many facilities or multiple facilities. It's harder to reach out to the other surgeon and tell them, relate what the exact problem is. They don't know what you're trying to relate to them. So.
Oh, absolutely. There he is, Hassan.
Hey guys, how are you?
Hey.
Hello.
He's putting on his scarves. He's putting on his doctor uniform. Superman.
I'm trying to look professional, you guys.
I see you, man. I see you.
Here we go.
Hey, meet Dr. Rachel Martin. She's our new podiatrist.
Oh, hey. How are you, Rachel?
Good. How are you?
She's married though, all right?
Good.
She's married.
You know what? I gotta put on my other glasses to really decide. And look at my hair. Who wants to look at this guy right now?
No, he's got the baseball cap on, so it's okay.
Okay.
Yeah.
There we go.
All right, Dr. 𝙤𝙤𝙞𝙨 is an interventional cardiologist. He does a lot of coronaries, but also peripheral. But he's so into like wellness and staying healthy. He even has a gym at his clinic teaching people how to work out.
That's awesome.
Yeah, look at him. He's fun.
Yeah, we'll see about that. So, is this your first job? You look pretty young.
This is my first job out of residency. Just
Oh,
graduating.
that's exciting.
It is. It's very exciting times.
Do you remember your first job, Dr. Kim?
Oh, absolutely. I worked in East Valley with the Chandler Regional and Mercy Gilbert hospitals.
Okay.
Yeah, I joined a small surgical group. And man, every night at like 3 a.m., I would get called for appies, gallbladders, DVTs, cold feet, everything.
Wow.
Oh, really? How did you do vascular?
Yeah, I was doing vascular and general surgery in the East Valley, and yeah.
You know what? I got to respond to this person. 1 second.
Yeah, no problem. We'll continue our conversation.
Yeah. My first job, the way I look at it is, you don't know what you don't know, So you happen to be in good hands right now, but you could end up with the wrong group, right, Dr. Kim? Because you don't know any better. You're going from a resident in in an assembly line of medicine, and then all of a sudden you're in the business world, right? And you think you're going to practice medicine, but it's actually the business world first.
There's a term in podiatry that podiatrists eat their young. So I was, very apprehensive coming out the job that I took, that it was, going to be a good fit for me. And I think this is going to be a great fit. So I'm very excited.
So is this not to get into you guys' business? So is it an employed position, or are you doing revenue based? These are the things you consider, right, when you first take a job?
Yeah, it's an employed position.
Okay, good. Yeah, that's what I recommend too. Be employed as long as it makes sense.
Well, nowadays with the decreasing reimbursement, solo practitioners have a hard time. It's incredibly difficult in terms of navigating all the prior auth denials.
Now you're telling me? Now this guy tells me.
I mean, not only that, you got to deal with people quitting all the time, MAs not showing up, front office not showing up, computer going down. I mean, the list of problems you got to deal with.
Dude, I almost died like 3 times this year because of like 3 or 4 of the things you mentioned. But you can't prepare for these things. That's the ironic thing, right? Someone can tell you, okay, your MA may not show up, but like, okay, I'm still going to go and do this. And if she doesn't show up, I'm going to be screwed. There's an element of you're going to get screwed regardless. You know what I mean? And you just have to learn by experience. And that's kind of like the daunting thing as a doctor going into the business world, because you come out of training like very competent in certain things, but then you're required to know all these other things so you can implement them properly. It's crazy.
Yeah, absolutely.
I think the focus of residency and fellowship on all this training is to become that mechanic, the surgeon, the doctor aspect of it, and nothing more. Like, they don't train us how to navigate the billing code. I didn't know what CPT code was, ICD-10, whatever number is now. I didn't know any of those codes. I didn't know what credentialing means. Nothing.
Right.
So literally we come out and thinking, okay, I'm just going to do my surgeries and see patients, and that's it. And then hope that other people know what they're doing.
Yeah. I mean, this discussion can quickly change into whether or not you want to be employed or not employed. But also, I've been like joyful while being employed, just doing our doctor thing. You know what I mean? It's just such a privilege to be able to do that. So even if you're employed or it's your own business, I think we're lucky we can just rest on that because we have a direct way to help people. Some other professions are like, yeah, I do this to help, to do this, so we can help people. Ours is like very direct and very intimate, and I find it very like enriching,
Rewarding.
rewarding.
The most rewarding part is when a patient like brings a whole basket of food saying, thank you, you really helped me. I saw 5 other doctors, they just dismissed me, they didn't know, they didn't box it all up, but you saved me. That's the oh my God, that's the cream of the crop. That's when I just go, oh my God, I've done my job. And the worst part is like if someone gets a complication, I feel like, oh my God, I'm such a bad doctor. How could I forget? How did I not add more antibiotics as a prophylaxis? But we can go on regrets forever, but just kind of have to rely on the training and do the best we can.
I noticed you have a new background, Dr. Kim.
Yeah, I know. I forgot to remove it. It's
no,
the
I like it.
It's the background that we have for all our company members.
Wait, are you wearing a t-shirt? You're not allowed to wear a t-shirt. You have to wear scrubs. If we're gonna get informal, that's it.
I don't want to strip on a podcast, man. I mean, I don't mind showing my 6-pack or 8-pack.
We're gonna enjoy our guest for a second. So Rachel, so how are you a fit doc? Wait, what's the name of our podcast then?
Buff Doc. Buff Doc.
Buff Doc.
Well,
there we go.
Yeah, fit doc.
Yeah. So you gotta when you start your interview, our guests all have to go like this. We just gotta see it. There you go.
There you go.
There you go.
Messing around. And then look at this guy. Okay, all right.
Oh, all right.
That's enough flexing.
Yeah, so clearly you lift some weights. I saw some upper body there. What's your routine like?
So me and my husband go to the gym and we do like back and bis or chest and tries together. But I like to do more cardio, so I'll either do like the elliptical. We have a bike at the house that makes it really convenient to just hop on the bike whenever you're home and you don't really feel like going to the gym and doing that kind of like going all the way to the gym. I should say it's really not that far. It's like 20 minutes. But I think it's just important to incorporate some kind of exercise into your routine, whether it's a formal exercise or like just something that you a hobby that you enjoy that is exercise. So over the summer, I really got into paddle boarding. That was really good core exercise and really good, upper body exercise. It's a little hot right now to go, and when I lived in Indianapolis, there were so many bodies of water that you could just hit up any time. So that was really awesome. But I think it's important to find a hobby or sport that you like to do that's active, that can get you out there.
Yeah, that's lovely advice.
What I recommend all my patients is find something that they can do without too much hassle, without, the paddleboarding is great, but you got to go out to the lake. You got to take time out. It's got to be something consistent, like walking, Yeah. This morning I was running 5 miles. And I saw these people like riding bicycles in the middle of the road in their bicycle lane. And I'm thinking, okay, they're delusional.
You're gonna get hit.
Just because they painted that it's bicycle lane, there are cars switching by. It's such I don't know who came up with the idea, thinking that that's safe to bicycle right next to cars that are going at 50 miles an hour and thinking that's an exercise. I would say, you know what? Forget that. Just walk. Walking is one of the best exercises ever. Walking or, a little light jogging if they can. But if they can't, they can still walk.
Yes, absolutely. I think exercise is not the same for every patient across the board. Like you're saying, like some people it's walking, some people it's running, but everybody can do some sort of exercise. There's no reason that you can't do exercise for some reason. I feel like patients try to make an excuse. I'm like, you can walk or you can do something, you can do upper body. If you can't walk, you can lift water bottles. There's something you can do.
Yeah. A podiatrist friend of mine kind of told me that all the intercostal muscles as well as the Achilles tendon, that it kind of prevents the injuries. Is that true? I don't know. Was he just making it up?
I'm sorry, you kind of cut out. You said something about the intercostal muscles that it prevents.
Yeah, no, just by kind of working on the calf raise, exercise. There's not too many exercises you can do with your feet except the calf, raises. But then that strengthens the tendon, Achilles tendon, and then also strengthens all the bones and muscles in between the toes because it's stabilizing. Is that the mechanics of it?
I personally haven't heard that before, but that makes total sense. Yeah.
Okay. All right. Well, that's what I do. So
yeah, I would recommend it. And it's stretching, so I always recommend patients to stretch.
I don't know. Yeah, Hassan, did you get your workout in today?
I did a lot of ankle stuff. Now that you guys mention it, I had an ankle injury like a year ago, and I still feel like there's spots in there that need to be stretched, like rehabilitated.
Okay.
And I feel like patients are like for example, when we're children, we're taught, or we just automatically know, you're thirsty, you go to the fridge, you get water. You're hungry, you get food. It wasn't really instilled in us that to maintain a human body, it needs exercise. That was never really a concept that's in the mainstream way of thinking. So subsequently, it's almost like, and then we're all like, we're hyper developing technology, etc. Less need to walk or exercise. So then it's almost like, why should I exercise? I'm a sophisticated Homo sapien 2.0. I can do everything from here. You know what I mean? So there's almost like a bourgeois element to exercise almost. And it's almost like you got to get in there with the common man and just, work the earth and stuff like that. So I think people have to just rehabilitate their mind with how they feel about exercise, that is something very fundamental to our human bodies. I mean, if you look at a person coming up towards you, you just see a bunch of muscles and bones, and then you meet them, and then the personality and all that stuff. But we're just a bunch of muscles and bones walking around.
I mean, I'm version 3.0. I don't know where you are, but I don't know.
Yeah, well, definitely the next phase needs to integrate exercise. Like, I guess all three of us exercise regularly. We do it with our family members, which is really cute, by the way. I had a chance to do that very rarely throughout my life, where I work out with someone that I'm actually interested in. It's like a weird vibe where it's not weird. It's like, you want to show off a little bit, and then you want to help her with her form, and then it's kind of cute and encouraging. And it's a lovely thing to do, yeah.
One of the things that I try to do is combine the family time with the exercise. So this morning I took my boys. So every weekend I wake up my boys and go, boys, it's time to go run. And I drag them running, and we just run around, about a mile. So after my 4-mile run, I go another mile with them. But that alone, just sense of kind of having a family time. Even though we may not be having a dialogue or conversations, I can kind of teach them life lessons about discipline, waking up early, going to bed early, because they were up late, doing playing around, and so all those things was kind of being able to connect with them and teaching them. And I don't know, I find that pretty kind of helpful in parenting.
I bet you they learn just from being in your presence. Like, you don't actually, they just learn by example. I think that's really how most of us learn really deep-rooted things, by example.
That's a great idea to, make your kids go running with you and to incorporate bonding time with them. I don't think I've ever heard of too many parents doing that, but.
I mean, it's the same idea. If a doctor comes in, smelling like cigarette, I can't tell him to stop smoking because I'm smoking. It's like, okay, and how are they going to believe me or take my advice? But if I come in fit and healthy and then go, hey, you know what? Let's walk. Your circulation's so dependent on walking and running and just movement. Let's start a little bit. Obviously a lot of people can't. Some people had toe amputations, so it's really difficult, but they can still walk slowly.
Exactly.
Like, what's the percentage of deficit or degradation of the mobility, for each toe that you lose? Like, what are the numbers on the podiatry?
So your stride is shortened a little bit as you get some toe amputations, but it really isn't until you get a transmetatarsal amputations that it's severely shortened. And so if you just get like a pinky toe amputation, let's say, it really should not be noticeable, let's say. But if you were to get a hallux amputation, I would say it might be more noticeable. But when you start getting a transmetatarsal amputation, that's when you would actually start noticing someone's stride would be shorter. So.
And, what we kind of promote in our company is it all starts from good nail care, good foot care. Especially it's usually diabetic patients, people who can't, properly take care of their nails, and then it progresses worse, and ingrown toenail, or they cut it wrong, something gets infected, it won't heal. And so tell us a little bit more about the progression of the disease, proper toe care.
So proper toenail hygiene is very important in order to prevent these amputations, as we're talking about, because as your toenails, they might get longer and they might dig in. They could cause wounds, perhaps, as we're talking about. And if they cause wounds, if you're diabetic or if you have poor circulation, the wounds longer to heal. If they take longer to heal, the more at risk you are for an infection. You get an infection that gets into the bone. Unfortunately, your risk for amputation at this point is very high. You have to get an amputation, could be of the partial toe, a whole toe, or if it's even farther back, that's where we're talking about a transmetatarsal amputation. So that's why it's very important in order to have proper toenail hygiene. And when you're having this proper toenail hygiene, you're coming in, and we're also checking for your circulation in your feet at this time as well. So we can catch if you have peripheral arterial disease or vascular disease at this time, and we can refer you to the proper channels in order to get checked out and get these things properly managed at this time. So.
And the heart only exists to provide blood to the foot, right?
only that's its only job.
Yeah.
The feet are the most important thing.
Yeah.
I mean, without your feet, you have nothing.
Yeah.
I mean, so forget everything else. I mean, those lungs, liver, whatever.
No, I've had patients with BKAs and transmetatarsal amputations, and it's just they're just miserable. They're miserable. It's just so sad.
Yeah, it's not our favorite part of our job. So, with cell patients, it's not something that we look forward to ever having to tell someone that they need or we want to do. So we try as hard as we can to prevent those things from happening. And so we want to take care of it before it ever even starts.
The best story that I tell is when I was training in Detroit Medical Center, we were amputating literally one leg a day.
Oh my gosh.
Patients would come in smoking 2 packs a day, diabetic, hypertensive. We did bypass like 5 times. Every time it closed off, they don't want to take their Coumadin. They don't want to take their Eliquis. They don't want to take aspirin. Forget about it. And it just comes to a point. It's like, okay, this patient's going to die. Their leg has to go.
Mm-hmm.
Life just completely changes.
Mm-hmm.
It's just, yeah.
The 5-year mortality after someone has a BKA is worse than someone with breast cancer. Is the latest research. So it's.
Why is that?
It's because the comorbidities that come with having these diseases is what causes everything else to fail in their body. And so if they're getting these below the knee amputations, it's just a sign of everything else in their body is likely deteriorating as well. So we liked
coronary artery disease.
Yeah.
Part of the limb salvage program that we're part of at St. Luke's a couple of years ago, we highlighted the fact that once you're amputated, your mobility goes way down, and then it's a different life altogether. And then you're just sitting there, and all the diseases are coming at you. You know, we call hypertension the sitting disease. You know, the diabetes similarly from immobility. So then, you know, diabetes, infection. You get an infection, it's really bad, and then they, you know, end up dying of sepsis. It's not like, oh, it's just the amputation caused them to die, but it shortens your lifespan because primarily the mobility.
Yeah.
You know, how often do you have people that are like gung ho and fully embrace their limit? You know, if they have an amputation, usually it's very depressing. I mean, it would really knock me down. You know, and like all these brave people that they're, you know what, I'm not going to let it affect my life. They wear their amputation. They're exercising more than others. A couple of weeks ago, I saw this guy on Camelback. Have you guys seen this guy? He's like a buff guy. He uses crutches and his one leg, and the other leg is amputated, and he hikes Camelback.
Really?
Yeah, I mean, and he looks like he could be 200 pounds. He's a big dude, like big muscular dude. And he's like hiking Camelback with his prosthetic leg and two crutches.
That's
that's
impressive.
Yeah, I mean that's one side with the immobility, but most of the patients that I see are like they come in the wheelchair and they're just kind of like, you know, there's something bad underneath the hood and just feel terrible.
Yeah.
So it's basically twofold. Like, you know, getting an amputation is an indication that their comorbidities are just likely to be damaging others, but it also works with mobility, so it accelerates it. Without you mentioned something about, you know, mobility, immobile is a hypertension. Can you elaborate a little bit more?
Yeah, another, you know, how we come up with cute names to describe illnesses. The hypertension is the sitting disease. You know, diabetes are the sitting diseases. These are two diseases that can be prevented with just moving around. Like when you sit, pretty much every patient that I see that comes in hypertension, like younger than they should be, you know what I mean? Like 20s or 30s, they have a sitting profession, and or something just changed where they had a different kind of profession and now they're sitting and they're like this all day. And check this out. You know how sleep apnea is like one of the most common causes of uncontrolled hypertension? There's a thing called daytime apnea, where because we're so kind of like no longer like in our right minds most of the time, we're always like on devices, we're forgetting to breathe. So we're like holding our breath, and then I'll send you the article this week, Dr. Kim. It's really cool. It's almost as prevalent as regular sleep apnea, and they have the same clinical problems as sleep apnea. Well, from my perspective, cardiology, they develop hypertension, sometimes rhythm disorders, AFib. You know, anyone that has nuance at AFib and they're relatively young, it's sleep apnea, like 100%. Maybe it's this daytime apnea thing.
Isn't it just you know, waking or obesity that causes sleep apnea? Are you saying posture? And
well, it's a combination of posture. Okay, they get in this sort of compressed posture, which I was just in, by the way. Yeah. So yeah, it's actually the right posture. You want to be erect, so your vertebra can open up properly. It's almost like our usual working out postures, you know, the stand-up postures. That's the ideal one, because we get our strength from the curvature of our spine. This is a weak position, you know. This is strong because the weight can translate to the vertebra. But anyway, so this is like this. You can expand your lungs and take deeper breaths. But when they're like this and just like not breathing because they're so immersed in thought.
Makes sense. It's a shallow breath. You know, it's not engaging the lung.
I had a patient wear the sleep study, because you know those at-home sleep studies, the rings. Yeah. Have you heard of? Yeah, so they're pretty good. I've been using them on my patients as a screening tool. But I had one of the guys that I suspected was doing this, okay, a 20-some-year-old, wear it during the day, and sure enough, he was apneic during the day. I just had him wear it the whole time. Yeah. But this isn't something I came up with. I read this article a couple of months ago. So like I said, I'll pass it along.
So if someone's apneic during the day, is it just causing hypoxia? They're confused. They're not getting enough oxygen in their organs.
Well, I got to talk to you about brain scans. Have you seen these brain scans of people with PTSD, with trauma, with depression, anxiety? So they do these scans, which are similar to EMGs, or EEGs for seizures, but they reconstruct the active zones with colors and they coordinate what part of the brain. So, for example, let's say I was a depressed individual, like things will cluster in my parietal lobe, my hippocampus, like, oh, this guy is thinking about this all the time. He's so depressed. You know what I mean? Or if like an anxious young lady comes in, her scan would show like all red in the frontal cortex, anxiety. You know what I mean? If someone like more balanced or just normal stress, you'll just see nice everything kind of lit. You guys follow what I'm saying?
Gotcha.
So then you look at people with dementia, and it's just like you would expect. It's like some Harry Potter shit. It's like cobwebs, just missing stuff. It's so sad. It's so sad. There's no connection, just islands of separated, focused thinking, and they're not connected. You could tell this person is not doing well. Like and that's kind of like what Alzheimer's is. They're just kind of lost. They don't have connections with their memories. They can't control them. They're just like that. And what does sleep apnea look like? Like that.
What?
That's what these people with sleep apnea look like. They end up, it looks similar to Alzheimer's. It's so bad for you. It's so bad for you.
Huh. So
well, anyways,
cognitive
I'll get off that high horse of whatever sleep apnea talk, but yeah, that's it.
Oh my gosh.
Wow. I mean, that would explain, someone just being tired all the time, foggy brain, like just being foggy, and I don't know what's going on, and then just drinking more coffee.
I'm gonna take pictures of those brain scans that I described. I'm gonna do like screenshots, and the next time we talk, we'll just put those through. It's pretty cool.
Yeah, absolutely.
It's pretty cool. Yeah, that would be good to have that visual, because then you think about these things in real life.
Wow. I never really actually paid attention to, oxygenation and breathing, because it just comes so naturally. And I guess it makes sense. Like, if I am hunched over, if my neck's just kind of blocking off my airways, yeah, I'm probably getting less oxygen than I should. I need to.
Yeah. So then you hunch over and get more oxygen.
Yeah. Huh. That's why during the residency, when I was just walking around all the time throughout the hospital, running everywhere and drinking 5 cups of coffee, I was the peak of the alertness and cognitive ability. And now it's just like, I don't know, I need more coffee. I'm tired. I can't think.
Oh, wow.
I know. It's amazing what we got away with when we were younger. It's crazy.
Tell me about it. That's why our body just works all together without proper podiatric functions. For mobilization, we can't move around. We can't have a good posture. Everything suffers. It's almost like one little thing goes wrong, and then it can just fall like a dominoes. Everything else just suffers. Not enough blood flow to the kidneys, and now you got nephropathy and renal dysfunctions.
I mean, a lot of the vascular disorders really do start in the feet. People are just not. I don't think they're barefoot enough. They're not doing enough contact. So I think there's just a generalized neuropathy going on from that alone. They're like always like in the wrong temperature. I think our feet are more robust. Again, on Camelback, there was a dude that went up barefoot.
What?
I swear to God, this dude
What
was like
another.
This was 6, 7 a.m. or something. This dude went by barefoot, and I'm looking like what the heck? And I'm like, my theory was right. We do need this. This is an example.
He's gonna step on the cactus.
No, don't they have like sharp rocks in Camelback?
Dude, I wouldn't do it. I mean, everything looks sharp. I have old shoes.
When he gets a cactus in his foot, and I'll take it out.
Okay, I wouldn't recommend that to the patient. Like going barefoot is an extreme. Just healthy socks and shoes is sufficient, I think. Wow. Yeah, I mean, I think you know, when it comes to exercising and being mobile and moving around, it's almost like, you know, in my experience, I had to hit rock bottom literally before I realized, man, I'm killing myself with smoking cigarettes and drinking and not working out and just feeling so sluggish and tired and exhausted. I couldn't even breathe well. Like I was always coughing. Smoking is terrible. Now
I can't believe you ever smoked, Dr. King.
I know. I was just gonna say.
That's ridiculous.
I know it. I never thought I would smoke, but then just like I don't know where I saw it. Somewhere, some TV or something. I saw someone smoking. I'm like, oh, maybe that's a cool way to, relieve my stress. And then it just becomes an addiction. It's like,
Were you trying to impress a girl? Is that what it was?
It was like the commercial union.
It's always a girl.
One of those old movies where two guys light up a cigarette. It's like, oh man, that looks pretty cool.
Come on, young immigrant boy, want to impress all the American girls? I got it. I got you. I watched To Eden and Back.
Yeah, and then once I started smoking, I couldn't work out because I didn't have the stamina. It hurt everything. My body's overall inflammation, markers were really elevated. And so it was like a vicious cycle. Like once, one little habit, one little bad habit prevents the healthy habits. And then it really required me to reset. Like I had to go to a point where, oh my God, my labs are horrible. My cholesterol level is high. They're talking to me about, starting a statin medications. Like, man, I'm too young for this. I need to reset, restart, turn my life around, quit smoking. And vaping is a little better, right?
No, it's not. It's way worse. Oh my God.
Hey, come on, I'm trying to get your support here. It's
no, man, that's a bad idea.
Harmful than tobacco, no?
We do not approve this message.
Oh gosh, okay. All right, I'm not going to tell the patients that. But actually, it is a step down from tobacco. Obviously, tobaccos have a lot of carcinogens in it.
You guys give me 1 second. I have to attend to something.
Yeah. Oh boy. Yeah, so we just talk about anything random, whatever you feel like it. So tell us about your kind of treatment, your approach. What made you become a podiatrist? Like, why are you passionate about this?
Yeah, that's a great question. So when I was in undergraduate, I knew I wanted to go into medicine. I knew I wanted to do something surgical. And so I started shadowing a bunch of different specialties. I shadowed trauma and cardiology, and I liked them, but I didn't know if they were like really happy with what they were doing. And then I shadowed podiatry, and I really loved that they got hands-on in clinic, and they were doing like procedures in clinic, like ingrown procedures and debridements and ingrown toenails. And so then all the podiatrists were all super happy with what they did, and they had a pretty good work-life balance. And so that's when I was like, I think podiatry is what I want to do, as far as like everyone was happy, good work-life balance, and you got to do hands-on things in clinic. And so I went into podiatry.
Yeah, no, that's been my experience as well.
Mm-hmm.
Podiatry is one of the fields that combines the primary care and surgical specialty all together.
Exactly.
Right. So podiatrists are a primary, in terms of foot health-wise, you're the primary care doctors, but you can take it all the way to surgical reconstruction if need be. Obviously, you can do a lot of other conservative therapies with, cast and I don't know, whatever else is out there. And I think that continuity of care is what's great about podiatry.
Yeah, you can follow a patient from day one until surgery, and then even after surgery, they keep following up with you and for other problems. And sometimes other specialties, it's just, if they're surgical, it's just only surgery. And so, you never see them again. Exactly.
Like we don't take care of anybody else's, kidney problems or anything else. To say, hey, is it surgical? No. Yes. No. Okay.
Yeah. Exactly.
Send them back. Send it to internal medicine.
Yeah.
And the primary internal medicine are frustrated because they don't do the surgical procedures. Now the field is changing, though. A lot of internal medicine are going into the procedure oriented.
Yeah, exactly. So That's why I really liked it. And they were all really happy with what they did. And my residency director, when I was a student and I saw him, he was like, you chose the best profession there is. And so that was one of the reasons why I especially wanted to go to his program, because he was so passionate about our profession and really liked what he was doing. So,
yeah. And, you know, medical profession is a noble one. You know, a lot of us go into it because every one of us wants to help people in a certain way. You know, some people want to help everything about them, or they want to help them psychologically, you know, or certain aspects of their body. But I think the reward that us doctors get is the patient outcome. Like, you know, when they do well, they're happy, they're thankful, grateful. That's the best gift I ever received. And that just makes up for all the struggles, all the years of suffering and, you know, sleepless nights and working 100 hours a week. All that can be just instantaneously resolved by just a patient thanking me, you know.
exactly.
But, you know, Dr. Maki and I, we always talk about how the state of medical field is kind of deteriorating due to the reimbursement. A lot of the insurance companies, you know, the giant insurance companies are taking up everything. The giant hospital groups are taking up everything. Doctors are simply becoming an employee, a cog in the wheel. That's kind of frustrating.
It is. Yes.
Yeah. One of the things that we do well is, you know, initially I was an employee and then I started my own practice. And then it took me a lot of years to realize, man, we really need professional departments for every aspect of it. Professional, billing department, credentialing department, prior auth department, IT department, to handle all those computer issues that happen day to day. Scanner doesn't work. You know, initially when I had my own practice, I had to put on all the hats. Like, oh, scanner doesn't work, I had to go fix it.
Yeah.
They couldn't log in. Okay, let me fix it. All server went down. Oh my goodness! Now what do we do?
You're IT now.
Exactly. And then payroll. Not to mention payroll. You got to pay payroll taxes. You have to have people sign HIPAA agreements. What other requirements did I forget? Oh my goodness! It's just the regulatory red tape is mind-boggling. And that's why there's a lot of pattern nowadays for people, you know, that are small independent doctors just giving up. They don't want the hassle anymore. They just want to become an employee. Just, you know, hey, just give me some satisfactory work to do. And I cannot handle all the stress and headache of taxes and regulations and inflations.
I don't think it's for everybody. I'll be honest with you. So it may not be like the doctor's given up, like being that far into the business I don't think that's for everybody. You know, like I personally don't think that is for me. I'm tolerating it because I have a vision and stuff that I want to implement. But like the whole nuance of the business aspect is, you're right. I would rather delegate it to some professionals and have nothing to do with it.
Yeah, personally, I don't want to run the private practice aspect of it. And so I'm happy to be employed and have someone else manage that aspect of it. And I'm glad that there are people that want to do that part of it, because that is not what makes me happy. I like to be the person that is seeing the patients and not have to spend my time doing the payroll or doing the IT part of it, and know that my time can be focused with the patients and doing the surgery and doing the call and doing the other parts of medicine.
Yeah, I think that makes sense. You just finished residency. That's perfect. That's all right. I have to go travel, chill, and learn about everything.
Yeah.
Yeah.
Yeah, I mean, I'm sure you've already met so many people from our group, like that are handling each different aspect of things, right? Just the EMRs stuff, scribe, you know, medical assistant, simple things like checking up on medical assistant, making sure they're doing the autoclave and autoclave testing, you know, all those quality control measures. I mean, think and multiply that by 100 for every little thing that happens in the office. You know, nail tool, if it doesn't get autoclave correctly, patient's going to get infections. You know, that quality control has to be there. it's kind of like mind-boggling. And then, so after a few years of really struggling to wear all these hats myself, I realized, oh man, I can't do this by myself. I need help. And I try to figure out who to hire to build a good team of people that's going to be running things smoothly. And yeah, it took a lot of years. It takes many years to build that.
So you feel like you have a good team now to implement your business vision?
Oh, absolutely. We have a rock solid team and infrastructure. Not only the team, just the experience of all the mistakes that we made. So I can recreate it overnight. If everybody left tomorrow, I can recreate the entire company again in a couple of months. It takes time to hire.
Do you have the same people kind of doing the medical businesses as the other businesses? Does it go through the same people, or is everybody kind of different and you're the middle guy between the businesses?
There are more executives that are supervising all the other different divisions of the organization, but core managers are, specialty managers are focused on their field. For example, the call center, the scribes,
So you don't have like a right-hand man type of thing that manages several of your businesses or anything like that?
Well, I mean, I do. I have a good team of people, but it's never. It's not like you just hire someone and you can just let it go.
Yeah.
I mean, maybe if you're an Amazon size or something, it's possible, but I haven't found that to be true.
So if you go on vacation, is there like someone you can leave everything to, and you can like turn off?
Oh, I don't take vacations.
That's what I was saying. Like, I guess that's what we're kind of.
Oh, no,
seriously, you don't take vacations?
No, my work is my vacation. I enjoy it tremendously.
That's awesome, man. That's really cool. You don't crave like going to the ocean and not having any electronics, just nothing. You don't crave that?
Oh no. I don't get stressed. This is just relaxing, following up with people, solving the problems.
I don't look at that as de-stressing. I think that's just a thing that I enjoy, to go, just not to be unattached to whatever. Right?
Oh, I get bored. Let's say I get bored, within a couple of hours, I'm gonna want to come back. Like,
yeah, dude. Yeah, you're way more driven than I am, then, for sure. I guess we've already established this.
No, you know what I find the best. I don't live my life waiting for retirement or waiting for vacation. I live my life in a day, in a segment, present.
Yeah, for sure.
So I have a balanced day. I work hard. And then I have time to go to the gym for myself. I have time to spend with my kids. We're doing some pool party, inviting the elementary school kids over for these end of the summer pool party. That's going to be really fun, watching them play and be joyful. And, spend some time with my baby. And then I go to sleep early and get a good night rest. I don't know. I think, obviously, I haven't always been like this. I was super stressed out after residency. I had a few years where I still had nightmares that I was not gonna, finish my residency because our attendings threatened us and screamed at us every day. We're gonna fire you. We're gonna fire one of you.
Sounds like you have some PTSD from residency.
I did.
You want to talk about
this? With a nightmare. I was thinking.
It's called suck it up.
Did I not finish my residency?
What? Kidding, of course.
I mean, those nightmares were real.
We're getting flashbacks, man.
No, it was real, and that's how it was a pyramid system. So they weeded out so many prelims and categoricals. Literally, they just fired and anyone who didn't perform. So making it to the chief resident and finishing the residency was challenging, but I enjoyed it. It was a lot of fun. Where else could I do a liver transplant? I can't do it now. I can't do a whip ball, pancreatic cancers, surgeries. I can't do AAAs now. But those are amazing experiences and opportunities to be involved in their care.
Yeah, they do huge surgeries. And was it Detroit Receiving? that where you're at? Were you
Yeah,
in Detroit receiving?
Detroit Medical Center. Yeah,
Detroit Medical DMC.
yeah, DMC. Yeah,
Yeah, I think it used to be called Detroit Receiving at some point. Maybe
yeah.
when I was a kid. Yeah, that's the big hospital in downtown Detroit. It was like a war zone for a while. A lot of gunshot wounds.
Oh yeah.
And then over the last, I would say 10, 15 years, they're kind of emerging as a center of excellence for cardiology. So there's a lot of the clinical trials are coming out of there. Yeah, it's like it's nice because being from Detroit, I feel kind of proud of that place. Even though I never did a rotation there, I've never even been there. But
You know what made you go into cardiology? I never asked you that.
cardiology, I think it started in medical school when I heard my first cardiology lecture, and something clicked in my mind. Something about how like this organ, like first of all, literally emanates electricity, and we can pick that up on an EKG, and it can tell you when it's hurting on the EKG or whatever, and then like it's such a rational thing, like when you start looking at the bundle branch blocks, and like so there's like a nice mathematical aspect to it that I enjoy. But also like cardiology is like in the thick of it, whenever a patient is really sick, they call on us. Like sometimes we'll have to clear a patient for a surgery, but of course we have to get them through their MI. So it's like a central aspect of a patient's care. And I love that it goes through internal medicine, where you have to learn all of medicine and then focus on cardiology. And so anytime they want to make residency shorter and stuff, I'm like, no, they shouldn't. They should make them longer, if anything, so people really get to know like what they're studying. And then finally, the main reason I enjoyed it was of all like the diseases you can have in whatever part of your body is like, for example, let's say you had a stroke. Well, you're screwed. Not completely. You could do rehab and hopefully, but there's some permanent destruction there, But the heart, most of the time, will recover. And most of the time, if you catch things at the right time, they'll recover. And even if you've had a heart attack, just think about it. How many people do you know have had heart attack after heart attack? It keeps giving you a chance. You know what I mean? And I love that resiliency of that. So that's the other major reason that I love the heart. But I could talk about this all day, obviously. I'll let some of the other people talk.
But I thought after heart attack, you have a scar and dead tissues in there that prevents the ejection fraction from resuming its previous.
Oh, I've seen so many people that had a huge heart attack, and through the right exercise, medications, and they'll get their heart function back. But you're right in that there's some tissue that's just completely scarred and it's not going to go anywhere. It looks like it looks totally different than the rest of the heart, and we know that's not going to come back, and it may actually cause more problems with rhythm disorders. Yeah, so there's definitely a problem there. But I've seen people like in their late 70s, okay, with a very low ejection fraction, out there chopping wood, taking care of a ranch, etc. So we have enough heart that even if we lose part of it, it's still a whole lot of living that you can have. You know what I mean?
Sure, yeah.
Like more than you actually may use it. Most of us underuse our heart. We're just sitting around and stuff and not really challenging it and just working with it, learning about it. Again, I can go on.
Well, sort of like kidneys then, like you still have a lot of reserve functions and recovery.
Mm-hmm. Yeah, that's why I'm a big fan of cardiac rehab. I'm surprised how many people don't end up going to that. It's free and it's available, and I'm a big fan of that. And they're not doing anything special. You look at the cardiac rehab equipment; it's like senior citizens' homes equipment. Like it's available everywhere. But the idea is right after you have a heart attack or a heart failure or whatever, that you go and you just start exercising again. You start seeing what's normal with your heart, building up your stamina. So maybe next time you'll maybe know the symptoms ahead of time. But it reduces mortality and revascularization and stuff like that, but like up to 40%. Amazing.
Wow.
Yeah.
It's amazing how just exercise and proper diet and weight loss can make every specialty, complications feel better. All right. I mean, with that, I think we're coming to the end of the hour.
Yes. Take care, you guys. Have a good afternoon.
All right, guys. Talk to you later.
Bye-bye.